Welcome to our first video on pericardial diseases. Let's begin. In this lecture, we'll talk about acute pericarditis and constrictive pericarditis. For each of these conditions, we'll discuss definition, causes, clinical presentation, diagnosis, and management. Let's start with acute pericarditis. Acute pericarditis, as the name implies, is the acute inflammation of the pericardium. Let's talk about causes of acute pericarditis. It is most commonly idiopathic. If the cause is identified, it is typically viral infection. Examples of viral causes of acute pericarditis include coxsackievirus B and adenovirus. Acute pericarditis may also be caused by bacterial infections like tuberculosis. It can also be caused by uremia in chronic kidney disease because uremic toxins induce leukocyte infiltration in the pericardium. Acute pericarditis can occur after an acute myocardial infarction. Peri-infarction pericarditis occurs within 1 to 3 days of MI. Weeks after an MI, Dressler syndrome, an immune-mediated inflammation of the pericardium, may also occur. Autoimmune disorders such as rheumatoid arthritis and systemic lupus erythematosus can also cause acute pericarditis. Pericarditis can be associated with surgery referred to as a postpericardiotomy syndrome. This occurs after surgical manipulation of the pericardium and can initiate an inflammatory reaction causing pericarditis. Acute pericarditis commonly presents with pleuritic chest pain that is characteristically worsened on deep inspiration. This is because deep inspiration increases diastolic heart filling and induces friction between inflamed layers of pericardium. Chest pain in acute pericarditis improves with sitting up and leaning forward. This is because leaning forward separates visceral and parietal layers of pericardium, reducing friction between them. The pain may radiate to the left shoulder. Pericardial friction rub can be heard on cardiac auscultation because inflamed visceral and parietal layers of pericardium rub against one another during diastole. Complications of pericarditis include pericardial effusion or cardiac tamponade, gradual or acute fluid accumulation in the pericardial cavities due to inflammatory exudate. In order to diagnose acute pericarditis, at least 2 out of these 4 diagnostic criteria must be present. First, the patient should have pleuritic chest pain relieved by leaning forward. Secondly, pericardial friction rub on cardiac auscultation suggests acute pericarditis. Again, the pericardial friction rub is a high-pitched scratching sound caused by sliding of inflamed pericardial layers along one another. Supportive ECG findings include diffuse ST elevation and PR depression. In other words, ST elevation and PR depression will be present in anatomically non-contiguous leads, making acute coronary syndrome unlikely. Please note that diffuse ST elevation and PR depression may not be present. Instead, there may be non-specific ST and T wave changes on ECG. Lastly, supportive echocardiography findings include the presence of pericardial effusion. However, the pericardial effusion is not always present in the context of acute pericarditis. Here is the ECG of the patient with acute pericarditis. Please note diffuse ST elevation and PR depression in almost all leads. Let's talk about the management of acute pericarditis. Acute pericarditis is usually self-limited and resolves on its own. However, management mainly consists of identifying and treating the underlying cause. Specifically, the patients with chronic kidney disease and uremic pericarditis need dialysis. On the other hand, the patients with autoimmune disorders require disease-modifying drugs. Viral and idiopathic cases are treated with non-steroidal anti-inflammatory drugs as a first-line treatment. Colchicine can be considered as an adjuvant therapy. Corticosteroids are typically avoided because they are associated with higher risk of recurrence. Peri-infarction pericarditis, occurring 1 to 3 days after MI, is usually treated supportively. NSAIDs are avoided because they might delay the myocardial scar formation. In contrast, Dressler syndrome, an immune type of pericarditis weeks after an MI, is treated with NSAIDs. Hospital admission for acute pericarditis can be considered in cases of high fever and leukocytosis or large pleural effusion. Let's try a question. A 28-year-old man presents to the office with chest pain that is worse when leaning backwards and better when sitting up and leaning forward. ECG shows diffuse ST elevation and PR depression. He had flu-like symptoms 2 weeks ago. What is the best initial management option for this patient's condition? This patient presents with chest pain that is worse when leaning backwards and better when sitting up and leaning forward. This pattern is consistent with the pleuritic pain of acute pericarditis. Acute pericarditis is further suggested by diffuse ST elevation and PR depression on ECG. Since he had flu-like symptoms 2 weeks ago, this patient likely suffers from viral pericarditis. The best initial management option for viral pericarditis is NSAIDs such as naproxen. Let's move on to the constrictive pericarditis. Constrictive pericarditis represents the stiff and non-compliant pericardium due to scarring from chronic pericarditis. Chronic pericarditis is the inflammation of pericardium that lasts more than 3 months. Let's talk about the causes of constrictive pericarditis. Similar to acute pericarditis, constrictive pericarditis is most commonly idiopathic. However, it may also be caused by cardiac surgery. This is because surgical manipulations and the pericardial penetration during surgery can induce the long-term inflammation, resulting in pericardial scarring. Exposure to chest radiation is another potential cause of constrictive pericarditis. This is because long-term radiation can also induce fibrous tissue formation within the pericardial sac. Finally, chronic infections like miliary tuberculosis can induce pericardial scarring that will result in constrictive pericarditis. Let's talk about clinical features of constrictive pericarditis. Narrowing of the pericardial cavity due to scarring causes decreased diastolic heart filling. This is because pericardium is stiff and non-compliant. Decreased diastolic heart filling results in decreased stroke volume and cardiac output. Signs caused by decreased cardiac output include fatigue and exercise intolerance. Additionally, the patient may have tachycardia due to reflex increase in sympathetic tone. This is because the sympathetic nervous system tries to compensate for low cardiac output. In addition to decreased cardiac output, the constrictive pericarditis causes fluid overload. The stiff pericardium does not allow the heart to accept sufficient blood. Blood, in turn, accumulates in the systemic veins. Backflow of blood in systemic veins will result in jugular venous distension and peripheral edema. An interesting phenomenon associated with constrictive pericarditis is something called Kussmaul sign. Kussmaul sign is the paradoxical increase in jugular venous pressure on inspiration. Normally, when the patient inhales, there is an increased venous return to the right side of the heart due to drop in intrathoracic pressure. If the patient has constrictive pericarditis, then the stiff pericardium does not allow excess blood to go into the right ventricle during inspiration. Instead, blood accumulates in the jugular veins, increasing the jugular venous pressure. Please note that Kussmaul sign is not a pathognomonic finding of constrictive pericarditis. It can also be observed in conditions like restrictive cardiomyopathy and right atrial and ventricular tumors. Constrictive pericarditis can also present with pericardial knock. The pericardial knock is the diastolic sound due to the sudden onset of ventricular filling. Sudden arrest of ventricular filling occurs because the scarred layers of pericardium do not allow the heart to accept more blood. Another possible sign of constrictive pericarditis is the pulsus paradoxus. Pulsus paradoxus represents the drop in systolic blood pressure by more than 10 on inspiration. Let's briefly discuss how it happens. Decreased intrathoracic pressure during inspiration increases the right heart filling and thus the end diastolic volume. This increase in right ventricular volume slightly limits the left ventricular filling and results in an overall slight decrease in systolic blood pressure during inspiration. This decrease normally accounts for 10 or less. During tamponade, the cardiac compression further decreases the left ventricular ability to expand, decreasing left ventricular volume and lowering systolic blood pressure by more than 10. Please note that pulsus paradoxus is not pathognomonic for constrictive pericarditis. It can also be observed in cardiac tamponade and the respiratory disorders like croup, asthma, and COPD. Here is the image showing jugular venous distension. Note the rope-like distended vein. Here you see the pedal edema. Note that the edema is pitting due to fluid transitation in the interstitial space. Let's talk about the diagnosis of constrictive pericarditis. Chest X-ray, chest CT, or echocardiography will all show the thick and calcified pericardium. ECG may reveal low-voltage QRS complexes because fibrosed pericardium interferes with myocardial electrical impulses reaching the electrodes. Please note that low-voltage ECG is not a specific finding in constrictive pericarditis. It can also be observed in conditions like restrictive cardiomyopathy. This is how constrictive pericarditis looks like on lateral chest X-ray. Please note the calcified and thick pericardium. This is the ECG showing low-voltage QRS complexes. Please note that the QRS complexes are smaller than they normally are. Let's try a question. A 59-year-old woman presents to the office with shortness of breath and peripheral edema. She has a past medical history of mediastinal non-Hodgkin lymphoma treated with radiotherapy. Physical exam reveals an increase in jugular venous pressure on inspiration. Chest CT scan reveals calcified and thickened pericardium. What is the most likely mechanism of the physical exam finding in this patient? This patient presents with shortness of breath and peripheral edema. The physical exam reveals an increase in jugular venous pressure on inspiration. This phenomenon is known as Kussmaul sign. Chest CT scan reveals calcified and thickened pericardium. These findings are consistent with the diagnosis of constrictive pericarditis. Constrictive pericarditis in this patient was most likely caused by chronic radiation exposure of the chest during treatment of mediastinal non-Hodgkin lymphoma. Kussmaul sign is present in constrictive pericarditis because the stiff pericardium does not allow excess blood to go into the right ventricle during inspiration. Instead, blood accumulates in the jugular veins, increasing the jugular venous pressure. Finally, let's talk about management of constrictive pericarditis. If detected early, the conservative management with NSAIDs and colchicine is the mainstay of treatment. Corticosteroids or immune modulating therapy could be added if the patient does not respond to NSAIDs or colchicine. Lastly, pericardiectomy can be done if the disease is severe or refractory to the medical management. Pericardiectomy involves removal of thick and calcified pericardial layers. Here's a table summarizing key points about the conditions we discussed in this lecture. Pause the video and take a moment to consider this table. Let's end this lecture with a question. A 62-year-old man presents to the physician due to fatigue and bilateral leg swelling. He has a past medical history of treated tuberculosis. Vital signs include a temperature of 37 degrees Celsius, a blood pressure of 135/85, heart rate of 75, and respiratory rate of 14. Physical exam reveals jugular venous distension and 2+ peripheral edema. Cardiac auscultation reveals an early diastolic sound. The systolic blood pressure drops by 20 on inspiration. ECG shows low voltage QRS complexes, while echocardiography reveals thickened and calcified pericardium. Which of the following is the best initial treatment option for this patient? A. Naproxen and colchicine. B. Prednisone. C. Pericardiectomy. Or D. Pericardial window. This man with past medical history of treated tuberculosis presents with fatigue and bilateral leg swelling. Physical exam reveals jugular venous distension and 2+ peripheral edema, the signs of right heart dysfunction. Cardiac auscultation reveals an early diastolic sound, which most likely suggests a pericardial knock. The systolic blood pressure drops by 20 on inspiration. This phenomenon is known as pulsus paradoxus and may indicate either myocardial or pericardial disease. ECG shows low voltage QRS complexes, while echocardiography reveals thickened and calcified pericardium. All these findings are classic for constrictive pericarditis. Constrictive pericarditis in this patient is most likely caused by tuberculosis infection. The best initial treatment option for the patient with constrictive pericarditis is NSAIDs and colchicine. Therefore, the correct answer is option A, naproxen and colchicine. Here is a slide reminding us of the management of constrictive pericarditis. Let's discuss now why other options are incorrect. Option B is incorrect because steroids, such as prednisone, are used for constrictive pericarditis only if NSAIDs and naproxen are ineffective. Option C is incorrect because pericardiectomy is considered for patients refractory to medical management. Finally, option D is incorrect because pericardial window is used in the management of pericardial tamponade rather than constrictive pericarditis. And that concludes our lecture on acute and constrictive pericarditis.